Hello, I'm Bruce Sands. I'm the Division Chief for the Dr. Henry D. Janowitz Division of Gastroenterology at Mount Sinai Medical Center, and I'm pleased to join Dr. James Aisenberg, who is Clinical Professor of Medicine, also a member of our division. We've been invited by the editors of Gastrointestinal Endoscopy to discuss the study, The Detection of Premalignant Colon Polyps During Colonoscopy is Stable Throughout the Workday, which appears in the May issue of Gastrointestinal Endoscopy. Jamie, good afternoon. Let me ask you the first question. Why did you and your group undertake this study?
We really undertook the study for two reasons. The first reason was in 2009 there were two studies that were published in the literature, one from Cleveland Clinic and one from the LA VA Hospital, both of which concluded that colonoscopy performed later in the workday detected fewer polyps than colonoscopy performed earlier in the workday. This implied that colonoscopies in the afternoon might be less preventative, less protective against colorectal cancer than colonoscopy performed in the morning. And the authors in both studies hypothesized that it was a cumulative fatigue effect related to performing back-to-back procedures over the course of the workday that was responsible. Now, this was sort of a catchy and plausible hypothesis, and it actually gained the attention of the lay press. So the New York Times or the Harvard Medical School Health Letter both published reports which were seen by readers around the world, lay readers around the world regarding this. And in fact, my practice here in New York, patients actually came in and they said, Dr. Aisenberg, is it okay I'm having my colonoscopy in the afternoon? Is that a good thing? Should I be having colonoscopy in the mornings? Now, in our practice, we actually, which is a group practice, we hypothesize that differences in conditions within colonoscopy or gastroenterology practice might mitigate these differences. So, for example, differences in bowel preps, we only use split-dose bowel preps, might mitigate this effect. Or moderated procedure scheduling, where we don't do as many procedures back-to-back, might also make a difference. So we aimed basically to analyze the impact of time of day in our practice. The other reason that we undertook the study was that we had an interest in sessile serrated polyps. And as most of our readers will know, sessile serrated polyps are an alternate pathway to colorectal cancer and have been implicated in so-called interval carcinoma development as well as right-sided colorectal cancer development. And we thought that our database would be an excellent database to begin to understand during routine colonoscopy how commonly are SSPs detected and so forth. So those were really the two reasons we undertook the study.
Well, great. It's an interesting idea. Maybe you could tell us a little bit about the methods of the study. What did the patient population look like, and what were the primary outcome measures?
For this study, what we did was we have a database, and we reviewed basically every patient who came in during the calendar year 2009, over 45 years of age, who was eligible for surveillance or screening colonoscopy, and who was endoscoped by one of three experienced colonoscopists. This yielded a population for the study of about 1,500 patients. And they were a typical colonoscopy screening population. They were about 60 years of age, 41% were male, 3/4 of them had screening exams, 1/4 had surveillance exams, and the average procedure length was about 20 minutes, and the mean withdrawal time was about 10 minutes. You asked about primary outcome measure. We chose to measure the detection rate for what we call premalignant polyps as a group, and that represented the sum of adenomatous polyps plus sessile serrated polyps. We thought those were the polyps that were the greatest, that was the outcome of greatest clinical importance. And we analyzed our outcome in two ways. We looked at hour by hour across the day, and we looked at a binary morning and afternoon analysis.
Great. Well, can you tell us a little bit about the results of the study? What did you find?
We found 47% of patients had at least one premalignant polyp, which broke out that 42% had an adenoma and 8% had at least one SSP. Now, in the primary analysis, we found that the detection of premalignant polyps and also of adenomas and SSPs in our practice conditions was independent of time of day. Now, this was true, this conclusion was upheld whether we looked in the hour-by-hour analysis or whether we looked in a binary morning and afternoon analysis. And in fact, we looked at each of the participating physicians individually, and the data was again upheld.
Well, you mentioned at the beginning that one of the things you wanted to study were the sessile serrated polyps, so what did your results reveal about that?
Great. So we have an expert GI pathologist who we use and who read all the slides, and we found in our group that the SSP detection rate was about 8% during routine colonoscopy. So if you do the math, that means about 1 in 12 cases had an SSP, and if you look at adenomas versus SSPs, the ratio was about 5 to 1. You know, this is a unique, this practice is one practice, and how generalizable those results are remains to be seen. It's unclear to me whether, you know, they would be the same year to year in our practice or, you know, in other practices. But nonetheless, this may be a starting point for trying to develop some benchmark data regarding SSP detection rate.
So Jamie, that's great. Maybe you could sum up and tell us what you think the take-home messages are from this study.
Thank you. You know, I would say, first of all, we found that under appropriate practice conditions, the premalignant polyp detection rate during the workday during routine colonoscopy can be stable. We hypothesized that bowel preparation quality may play a role in that. We also hypothesized that scheduling issues and issues related to production pressure may play a role in that, but those remain to be tested in prospective studies. The second comment I would make from this research is that the SSP detection rate is something that can be readily determined in a routine practice, and it may well prove to be an independent and valuable measure of colonoscopy quality.
Oh, great. Jamie, thanks so much for the discussion. It's been an interesting talk.
Thank you, Bruce. Thanks for being here.
My pleasure.